what they actually do, and are you getting what you think you're getting? Because I'm looking back on what I know. I was around when Vermont was proposed, and they had passed legislation, and people voted for it, thought they were getting single payer, and it was affordable. And it turned out it wasn't single payer, and it wasn't affordable. In California, they passed so many single payer bills that are just falling apart for various reasons. But most recently, they thought they were for single payer, it was affordable, and then they're told after it passed the Senate, when it goes to the Assembly, they're told, well, we can't afford it, and to get single payer, you have to have federal legislation, you have to have waivers. So
Jim,
what people
look
voted
here.
for was not.
Look here.
What people voted for was not really what they were getting. So I think that the basic idea is to try to clarify what's out there and what are you really getting. I think after your presentation, Erin Georgen from Whole Washington wants to respond to what you had to say. So she'll get like 5 or 10 minutes to respond after you talk, and then we'll take questions.
All right. Well, thank you so much for inviting us to be with you this evening. As many of you are probably aware, in addition to being a member of Physicians for National Health Program, I'm co-chair of our Maryland State chapter. We also run a campaign through Popular Resistance called Health Over Profit for Everyone. So if we were going to go through everything that Jim just outlined, we'd probably be here for quite a few hours. But there's a lot of material on the healthoverprofit.org website that talks about this. So I'm going to just kind of go in over some basics, and Kevin as well, of kind of conversations that we think are really important to be having in the single payer movement. We're not trying to tell anybody what to do. What we want to share with you is our experience and our perspective on this, so that you have the information, so that you can have these debates in your own communities about what makes the most sense moving forward. And I think that hopefully we all share the goal that what we really need is a national system. This is something that we're trying to create, like other nations have, a national system of social solidarity with so that every person living in the United States and its territories can get the health care that they need when they need it. So in Maryland, we've been having this conversation for a number of years now, and we had in the past supported kind of a state effort and gone through that process of writing legislation and lobbying our state lawmakers and holding hearing, testifying at hearings and kind of going through that whole process. But the more that we've learned, the less that made sense to us. And part of that is that you can't actually do a true single payer system at the state level. We have a very complicated healthcare system in the United States. And this is one way that we differed from how Canada was when they passed their Medicare for All system back in the late 1960s. We have a mix of state programs and federal programs. We have federal laws that block the states from being able to integrate these federal programs into their state system. And so if we call a state system single payer and it's not truly a single payer system and it doesn't get those savings of a single payer system, and then you add on top of that states are required to balance their budget, given not all of them do, and some states run a deficit. But unlike the federal government, the federal government is able to create money and can run a large deficit. States, when that happens, they have to start cutting back on other necessary programs like education and infrastructure and what have you. So it's a difficult environment for a state to create a true single payer system. Now, should states be trying to work towards universal systems, making their systems more efficient? In our view, yes, those are all good things to be doing. But if we label it a single payer and then we don't get the savings and the efficiencies of a single payer system, and then that kind of gives people the belief that single payer systems don't work. And our concern is that would undermine efforts at the national level. Both the state Vermont system and the Colorado systems were not single payer systems, but they were called that, and then they failed. So what are some of those barriers? I don't know. Do you want me to keep going? You want to talk about?
I'll do the barriers.
Okay.
Then we can go back and discuss the bill a little bit.
Right. I think that's important. Yeah.
Yeah. So first off, I want to say thank you again for inviting us. And I really love the energy in Washington State. In preparing for this, I try to correspond with 4 or 5, maybe 6 people in Washington State to try to get an understanding of what's going on. And there's a lot going on. As Jim said in his introduction, there's a lot going on. And that's just a fantastic amount of energy. And so you have a lot of people going into the direction of single payer, but you're going in different directions. And so I think it's really important to be as effective as we can. We are still a minority movement. We may have majority support, but the people involved are a small group, and we need to use our power as effectively as we can. And so that kind of solidarity, we have to figure out what's the most effective way to get to where we want to go. And I just want, before I go into some of the barriers, I want to say one of the things we need most desperately in the national single payer is we need to have Republicans sign on to HR 676. We have more than half the Democrats signed on. We have 0 Republicans. There are 0 Republicans in Washington State who've signed on. I'd love to see people in Washington State to look at the people who have not co-sponsored 676, Democrats and Republicans, and figure out what you can do to convince those people to join in. Because in the end, HR 676 is our best vehicle. We'll talk about that, is our best vehicle. But right now, as an only Democrat bill, that's not going to be very strong. And so if I was to focus your energy, I'd want to see that. Okay, now, as far as a state law goes, Margaret's right. A state cannot by itself put in place a single payer system. No doubt, if there were no federal laws involved, Washington State would have enough people to fund a single payer system. Or the state, with the federal laws involved, it makes it impossible. What you can create is a Washington State health system that runs alongside the existing system. And so you have a multi-payer system. And that multi-payer system, in the end, why, Jim asked, why is it California finds it's unaffordable when single payer is actually more efficient? Same with Vermont. The reason is because it's not really single payer. When it's not single payer, even if it's just Medicare that's not included in your system, it becomes, you lose the administrative savings and it becomes unaffordable. And so that's why, we all think single payer is more efficient, and the research shows it will raise a lot of money. Gerald Friedman's study shows that it's more efficient in Washington State, but Gerald Friedman's study is assuming all of the federal laws are changed or waived, and you get all those resources included. Yeah, sure, then it works. But that's 8 federal laws. And you have to think about federal laws as going through the Khyber Pass. It's not easy. And now, of those laws, a couple of them, Medicaid, the ACA, the Children's Health Insurance Program, which is part of Medicaid, those laws could get waivers. So you have to go through administrative agencies, HHS for ACA, and you have to go through the CMS for Medicaid. So you have to go to 2 different federal agencies to get those waivers. The bigger problem, though, is the federal laws, because to amend a federal law requires Congress passing a law. You have to get through the Khyber Pass 6 times in order to be able to do a state single payer program where all those resources come in to the state system. And I can go through those 6 laws and all the problems with it, but I just want to say, even if we get through all of that, we end up with a handful of states, maybe Washington, Oregon, California, Massachusetts, New York, maybe Illinois, maybe a couple others, who might get to single payer. All those other states don't. And so just like with Medicaid, which is a state-based program, we have this patchwork. It's not like Canada, where there are some differences in each province. There's only 10 provinces compared to 50. They don't have a confederacy. They don't have those extreme right-wing states that want to privatize Medicare, want to privatize Medicaid. And so even if we successfully got all those laws changed, what we end up with is the most likely states to support a national single payer getting their own single payer and then dropping out of the national fight because they've got their problem solved. So we lose our best advocates for a national program. And then what we end up with in the conservative states is the waivers that are provided for Medicare to allow a state to put in place its own program ends up becoming privatizing our single payer systems, privatizing Medicaid even more than it already is. And we could talk about that's another area where we want to see states take action, is to end to deprivatize, to make those public programs again. Medicare becomes privatized, becomes a voucher system where people can buy private insurance. The VA could become a privatized system, which they're trying to do, and become a voucher system. So all the single payer programs that exist get destroyed for a handful of states that might pass single payer. We are doing severe damage to the movement if we take that approach. This is the dream of the Paul Ryans. This is the dream of the privatizers, to destroy those single payer systems that are the most cost efficient part of U.S. healthcare and provide the best healthcare coverage in U.S. healthcare. They want to see those destroyed. And so our view, if people want to ask questions about specific laws, we can talk about them, but I don't see how you're going to change the TRICARE, which affects something like 8 million Pentagon workers and retirees. Several 100,000 of those are in Washington State. You're not going to get them to give that up so Washington State can put in place single payer. You're not getting through that Khyber Pass. That's harder than getting a national single payer program. You're not going to get the federal employees healthcare system, which involves hundreds of thousands of. We have 7 million federal employees in this country. The vast 79% are outside of Washington D.C. You have probably 60,000 federal employees in Washington State. You're not going to get them to give. You're not going to get Congress to force them to give up their choice of private insurance companies so Washington State can do single payer. That's a very difficult Khyber Pass to get through. And so you end up with a very multiplicity of challenges going through all these federal laws, both agencies and Congress. And the end result is, at best, you get a handful of states with single payer, weaken the national movement, and probably destroy the single payer systems we have. So misdirecting our efforts is actually helping our opposition. If there are just a few things I want to say, that and we're not telling you what to do. I mean, you guys decide what you want to do.
This is our opinion.
This is my opinion. This is what we've decided in Maryland, that our state is going to focus on national. But and by the way, I hope this discussion is taped and shared, because this is a debate that's been happening in many states. And so I hope that when we finish this, a tape is made of it, and it is something that's made available to other states to see as well, because this is really something we all have to get on the same page about. And once we get on the same page about federal law as our target, then we have to decide what federal law, because the Senate bill that Sanders introduced has lots of weaknesses. The House bill is the stronger bill, and we need to make sure that's protected and move Sanders as far to that direction. And there are some things in Sanders' bill we could improve HR 676 with, but the goal is to get the best federal law, get us focused on that to try to reach that as our objective. I'll stop there.
Yeah, I just want to make a few points. So a few things. So if you have a state system that is a multi-payer system, you can't achieve the savings of a single payer system. Doctors Woolhandler and Himmelstein estimate that if you add in a public option type of thing to the state system that you have, which is what these plans at the state level most likely will be, that you forego 84% of the administrative savings that you could have through a single payer system. Some states have, through their legislation, and it seems to be very common, it's the California approach, the New York approach, is try to do these workarounds around these changes to federal law. So there's discussion about having the state plan, whatever it is, Healthy Washington, be considered a Medicare Advantage plan that seniors could choose. Now that hasn't been done before. So far the Medicare Advantage plans are only private plans, but the current law says that we can't compel seniors to choose a particular plan. They have free choice of whether they want to choose the original Medicare or a particular Medicare Advantage plan. So even if you did have your state system become a Medicare Advantage plan, there's no guarantee that you're going to get all the seniors in your state to sign up for it. Similar situation exists with the federal employee health benefit plans. You may be able to get your state health plan to be considered a federal employee plan, but again, they have hundreds of choices of insurances and you can't compel them to choose your particular plan. The employer plans are a huge problem just in general because the ERISA law, Employee Retirement Income Security Act of 1974, and that's a federal law, and it basically prevents the states from being able to regulate employer plans in any way. And this includes anything, I've looked through the various cases and kind of how, read the law reviews of this, and basically anything that restricts an employer's ability to have their employer plan can be considered a violation of ERISA. Anything that seems coercive can be a violation of ERISA. And some states have said, well, we're not going to mention that we're banning employer plans in our bill because that would be a violation of ERISA. So we're getting around it by not mentioning that we're banning these plans. But that was an approach that Vermont used in a case against Liberty Mutual, where they were trying to get them to reveal their claims information. They just wanted to get all of the state claims information to know, how the dollars were being used. And they didn't say, employer plans have to give it up. They just said all plans, we need to get this. And so the court found against the state and said that was a violation of ERISA to require that company to turn over its claims and information to the state. Some people point to Hawaii and say, oh, well, Hawaii has an ERISA waiver, so that must set a precedent that other states can get an ERISA waiver too. And the reality of that is that Hawaii actually created an employer mandate type of system before the ERISA law was created. And so when the ERISA law was passed, there was a carve out for the Hawaiian plan. So that's a very unique situation. So
there's been no waivers since it was put in place, and every court decision.
Well, there's never been a waiver.
There's been no waivers ever since it was put in place.
Right.
And every court decision's come in favor of the employers, the ERISA
right.
plan,
and against the
state.
Yeah.
Every decision.
So we don't have any good legal precedents there. But I think that I think the one concluding comment that I want to focus on is the idea of putting in a congressional bill that would allow these changes of law to be made so that a state could have try to create a single payer system. And this has been tried in the past. Wyden and Brown tried it. I know McDermott talked about it. Sanders talked about it back in 2010. And this was really widely opposed by organizations like Physicians for a National Health Program, because it would dismantle our Medicare system, our federal Medicare system, and it would allow, once you open that door, and we all know how Congress works, when you open that door—
or doesn't work.
Well, it doesn't work for us. But what you're then allowing is states to, some states might do things that benefit Medicare populations, but other states will definitely do things that harm the Medicare population. And this is what the right wing kind of those who are kind of that free market ideology, they would love to see us dismantle our public systems by putting them into state control, because that allows— we just have a long history in this country of regressive states that use these opportunities to cut access to these public social safety nets to their population. And so it's a very I think dangerous and a slippery slope. But just ultimately, this is a fight. This is a national fight. This is our country. We want every person in our country to have health care. We want every person, including ourselves, to be able to travel around the country and feel secure that we can get health care no matter where we go. And when we break that down into a state fight, then we're really undermining our ability to create a national system. There's no guarantee that if a state or two states pass a single plan, that's going to become a national single payer system without a national movement to be pushing that. Canada, again, it was a very unique situation that we don't have here in the United States, where they had already federalized, or, the
Nationalized.
well, the national government had already given all the provinces coverage for hospital coverage. They said, if you put in place a universal hospital coverage system in your province, we'll fund it. And so they were already kind of halfway there. There were already experiments going on in a number of states to socialize their healthcare. Provinces, sorry, to socialize their healthcare. And so it was a different environment than what we have now. And they actually had federal laws that made it easier, not federal laws that stood in the way of that system. Quick comment on what the point that Jim raised about these new plans that are kind of being floated out there. The Medicare Extra for All, there's, Choose Medicare, but they all have these various names. And the fact that they're using Medicare is interesting because it shows that we're actually winning. And this is what you would expect at this phase of the fight, is that our power holders, the members of Congress, are going to try to look like they're actually giving into our demands, that they're actually on our side. And so they float out these ideas that have the names Medicare in there, but that actually preserve the status quo. And so it's really important that we not get fooled by these public options, buy-ins. None of them are actually going to change our healthcare system in the fundamental ways that we need to change it in order to have a universal, affordable, guaranteed healthcare system. So I'll stop there.
I just want to say on that last point you're making, we need clarity on where we're going. And there's going to be lots of, Margaret described how the people in power see Medicare coming, Medicare for all coming. They see national improved Medicare for all coming, and they're trying to figure out how to survive in that environment. Medicare Extra for All, Medicare Buy-in, Choose Medicare, all fake diversions. Our laser focus needs to be HR 676. That is the gold standard. It can be improved in a few ways, but that's the gold standard bill. We need to focus on getting Republicans and Democrats to make this bipartisan. Republicans should support this because it is efficient, it's good for business, it's good for the economy, it's good for state and local governments. All those areas relieve a great deal of pressure of healthcare costs on businesses, on state and local governments. And so this is there's strong arguments for Republican support. And that's where we should be focusing. Make HR 676 unstoppable. If we do that, we'll be in a position to win. Margaret mentioned one thing that I think it should be a good story to tell. How when Medicare was created, initially it had a plan that was different from what we ended up with. And because of these Southern Dixiecrats, they created a system that made it very hard to go from Medicare for elderly to Medicare for all. Describe that for a second.
But I also wanted to mention that the reason why we want bipartisan support for our final legislation is that we don't want it to become a political football like the Affordable Care Act has been, where it's actually a Republican ideology, but the Republicans hate it because the Democrats passed it and have been, trying to undermine it for all these years. So we want something that actually everyone supports. And it was actually a conservative finance minister in Canada who was tasked with looking at what the country should do, and looked at what was happening in Saskatchewan and said, this makes so much sense. We should be doing it at the national level. But, it was a civil rights movement that really made Medicare possible, Medicare and Medicaid. Initially, it was supposed to be a single system that
called Medigap, I think.
I don't remember what
Something
it was called,
like that, yeah.
but it was a single system, for the elderly and lower income people. But Wilbur Mills, who was a Southern Dixiecrat, he was the chair of the House Ways and Means Committee and a racist, and he put in the poison pill into the legislation of making Medicare a federal program with two parts, Part A and Part B, and Medicaid a state-based system. And this was called a three-layer cake. And it makes it very hard when you have this very, a disparate system, this complex system. It's much harder to expand it. And, the part that's been expanded is the Medicaid, and that's been the poorest part of our system. And we see how states struggle with that. And there's a great variation from state to state. So we'll stop there and take some questions.
Trying to listen. So I want to start out by just saying that I fully support a national effort. Our organization fully supports the national effort. I tell all of my volunteers and new recruits to also support those efforts and help educate them about why a state level approach can only achieve so much savings. It can only achieve so much efficiency. The other thing is, we try very hard to call the legislation, if you read it, as well as our materials, it's not a single payer plan. It's as close as a state can get, which is a universal approach. Okay. So it's based on models in other countries that are not single payer plans, but have a universal set of benefits that are incentivized to be nonprofit in the biggest way possible and that are financed in the most efficient way possible. So just to clarify, you're right, we can't achieve single payer at a state-based level without some miracle of waivers being granted that currently can't. They just probably wouldn't all be granted. The other thing is we don't fully try to approach that. Gerald's study does not include VA being incorporated. It does not assume that IHS will be incorporated because that requires tribal negotiations that we felt like the tribes should try to do that with the governor, not our initiative. It also doesn't fundamentally change how employer liability insurance in Washington works. So it doesn't. I'm brain farting on the program. L&I. I'm sorry. It doesn't change how L&I would work. So that's part of it. It does look at those costs, and it assumes that any care provided outside of those systems will have reduced costs, but it doesn't assume that those agencies will not be in control of them. The other thing that it does is that it assumes there will be challenges to the waivers. The waivers may not be granted all at once. We may get the Medicaid waiver easily, which looks at you look at the federal level, nearly every state has some waiver to Medicaid. So that's an easier one to negotiate, but Medicare would be quite hard. So we direct them to try and achieve them because it's great. Any of them that they can get would save us a little extra money and take out one extra middle agency. But in the meantime, this will be a publicly funded healthcare insurance that supplements existing programs and would be able to contract to administrate the benefits. So it would contract with the healthcare authority to administrate Medicaid. It would contract with the Federal Employees Health Benefits Board. It would contract with CMS, just like an insurance company would, except that this will have state level funding. Now, federal laws don't prevent states from self-funding additional benefits. For example, our state already has a public entity, the Long-Term Care Board, that is a public entity that contracts with DSHS to administrate long-term care benefits to our residents, especially in counties where there's not very many providers to choose from, insurance providers. So that's something that our state already does, also for abortion coverage for low-income residents. It's a state-funded program that goes outside. So we take the approach that it will have to be an elective process. People will have to want to enroll. So what we can do is use that state funding, the new revenues that we create, and it's about $29 billion worth of state level revenues, to make sure that the benefits and the premiums are better than anything that these people would be able to purchase through the Federal Employees Health Benefits System, through Medicare Advantage. It'll have a wider network than Medicaid because it'll supplement Medicaid costs to make sure that providers are getting rate equity. So essentially, it's just a state insurance designed to produce a universality to the best degree possible. The premiums are capped at $200 a month for adults earning over 200%, and that is designed to work within the government, the federal laws for these programs. But to cap it so that it will always be a lot lower than it would cost to do it now. But the board is instructed to get rid of those if possible over time, if there's enough funding in the program. Now, I wanted to talk about some of the other barriers. I totally agree with you about we need bipartisan support for healthcare reform. And I think that for some people, it is easier for them to consider doing it at a state level than a federal program. And I can debate with them all day long about how much better it would be to have a national plan. But this is an avenue where we're getting to have those conversations with people who wouldn't necessarily be willing to discuss a federal level plan, at least not now. I'm hoping that this will inspire them. That's the idea. We show as a state that we can achieve significant savings by making sure that everyone has a better set of benefits, that providers can negotiate their rates in a better way, and that the healthcare system actually considers residents' health needs. Because we add a provision that those funds will also be used to help shore up the healthcare system. Providers will be able to negotiate if they're nonprofit and have 5 or more practitioners. They'll be able to negotiate for supplemental funds, global budgeting funds, to help with those costs. So that will help our rural area providers a lot. Now, there are 256 different insurance plans available through federal health employees benefits. You can go online right now to their website, and it'll tell you how you can become one of those insurers. And nowhere on there does it prevent states from having a public entity do that. Same with the Centers for Medicaid and Medicare Services. They have a handy little guide that even tells you how to become an insurer for their program. And I can go down the list. Every program is designed to be contracted to insurers. So what we are doing is working within the system we have to achieve the most efficiency we can by establishing a public health insurance that everyone in our state can enroll in, and that businesses can cover their employees under for half of what they're paying now. And it will have more benefits and cover all of their employees. So we're very confident that the restraints that we put in the system on costs are going, and the package itself is going to make it the best option. We're going to easily get 80% of the population without a lot of effort. And if not, the idea that rolling more people into a bargaining group and having it non-profitly funded with state level revenues is not going to achieve any savings it's just a bit silly. If we don't achieve the maximum savings in the first year, then we'll achieve a little bit more the second year, and it'll become more efficient third year. Our legislators at the state level will be able to achieve more things because when they pass laws that affect state level Medicaid rules, it will now be something that the new trust has to make sure that they implement. So the expanded benefits that our wonderful legislators and governor and HCA have already achieved through waivers, that will apply to the new health insurance trust. If they expand CHIP benefits, that will apply to the new health insurance trust. So it's already better benefits than what exists under those programs, but should they make other advancements, the trust will provide a single benefits package that will include that advancement, because that's what their job is. Let me see, I wrote a couple other notes here. The ERISA benefits, it is true, we have a provision in our bill that explains that it doesn't change ERISA benefits, but the ERISA laws don't necessarily prevent us from trying to establish a state level public health insurance that businesses can enroll in. And again, this would cost them half the cost their cost right now. But what our proposal doesn't do is prevent employers from supplementing it. So these businesses who are actually paying the highest prices because they don't have very good bargaining power as self-funded health insurance plans, they can enroll their employees in the state plan and then continue to supplement, but they will save on hospital care, drug coverage, rehab services, and a multitude of other benefits that will be covered under the trust. So it's just, we need a better option that's truly universal. Right now, it's all divided up. And this is an opportunity to show that when you expand coverage, when you focus on nonprofits, when you care about everyone in your state, when you translate premiums and copays and out-of-pocket costs into a tax, that it actually does create a system that is more fair, that is more just, and where you know how much you're going to have to contribute no matter where you are on the income scale, or whether you're healthy or sick. Let me see if I have any other notes here I was jotting down. Oh, yeah, and about national efforts. This was something I wrote down earlier because the discussion about state-based efforts taking away from national efforts is one that bothers me just a bit, because the US is a republic. It's a republic, constitutional republic of states, right? It has individual states, and every major effort of advancing rights for people in the United States or changing the laws has been started at the state. For example, slavery was ended over a long period, but it began as a state-based abolition movements between 1790 and 1860, where the northern colonial states slowly, over nearly 100 years, abolished slavery. Later, they would become the Union states. Women earned the right to vote decades before the 19th Amendment was ratified by states. Kentucky was the first statewide women's suffrage movement, and that was in 1807. The public education system started actually in the colonial area. The first free taxpayer-supported public system in North America was Mather School in Massachusetts. After the Revolution, the northern states especially emphasized education, and they set up school systems. By 1870, nearly all states had tax-subsidized elementary schools. To be clear, we didn't have a federal system till years after that. State-based movements in civil rights were often found in the courts, where people were doing state-based courts or state entity were being either challenged in a court, or the state entity was challenging someone else in a court. The first minimum wage actually started in 1912 as the state of Massachusetts passed the first minimum wage. Both the criminalization of cannabis and the decriminalization of cannabis happened over decades at state level. Washington became the third state to pass guaranteed paid maternity leave last year. Automatic voter registration was succeeded in Oregon and Washington. Medicaid expansion was just passed via ballot initiative in a state in the US. So I would find it challenging to find anyone who would suggest that those state-based efforts weren't hugely important in achieving the national movement. We are a country that builds locally, where your vote has actually a lot more weight to it, and then advances policies towards the federal level. It is a national fight. We are in a national fight. This is just one small piece of it. And I don't know at what point a state will achieve it, but I sure hope that it's soon, because I do believe that that is what's going to lead to a federal change, to real support from bipartisan groups for a federal plan. So I hope that you'll join us and support us in trying to make sure everyone in Washington has health care and that they can afford to see the doctor. And that's really all I have. I can't speak to the waiver issue, except that because I haven't seen the language yet, her amendment. So it's difficult for me to gauge what Pramila's efforts look like. It is really important to me that waivers, I know that the waivers exist and that's our advantage, but I want federal waivers, any amendments to that to be ones that set bars that states can go beyond, but can't go below. And that's really important to me. So I'd love to hear how we can help push that, where the waivers are stronger in setting minimum standards and not allowing states to forego their responsibilities but still allow states to pursue better and to do more.
Is that the voter initiative? I didn't know that was a law or the initiative that.
Oh, yes, I'm sorry. That is the I-1600, but it's very similar to the HB 1026. We did add the express language about how to contract, and we did add revenues to make sure that it was funded, and adjusted some of the language so that it was more voter friendly. But the healthcare aspect of it is very much from that frame language.
And what did your pre-polling? Maybe you did, I don't know if you did polling or not. Did you do polling before you put it forward? How did it do?
We are a grassroots effort. We're totally volunteer organization. We have thousands of volunteers across the state. The polling that we did was that we had an extremely transparent and open process in drafting. We went through 8 different drafts, and each one got discussed and viewed by businesses, whoever would talk to us. But we got like hospital organizations, various businesses to come talk to us, individuals. I had a lot of lay people willing to read it who gave me feedback. And we stopped at the point when we stopped getting questions that weren't related to legal language that just had to be there. We stopped at the point where most people were really excited and satisfied and actually trying to read through it. I realize that's not a poll. We do have someone who's going to be polling the initiative, and I'm very excited that an organization volunteered to do that, because I'm not afraid of the results. We need to know where, I apologize. We need to know where we need to campaign on, where we need to adjust our message. And we also need to know whether we nailed it. But we didn't have the financial backing to pay the tens of thousands of dollars for a poll. So we're going grassroots and using the civic hurdles that exist. If we make ballots and keep going at the rate that we're going with volunteer support, I'm very confident that that's in a way a poll, because those are people that read it, asked questions about it, and then actually went out and tried to teach other people about it. It's been a fascinating experience. So I'm very hopeful, and I'm confident that it's a good proposal. It's up to the voters of Washington at this point, what happens next.
Great. I really liked a lot of what you had to say. And I particularly like that you're not calling it single payer. I think that's very important, because already we're told Vermont couldn't pass single payer, Colorado couldn't pass single payer, California couldn't pass single payer. If they can't pass it, then how can we expect the national to pass it? So, you know, if we label it single payer, we can do damage to the national movement. I think so I'm really pleased that you're talking about universal coverage and not using the word single payer, because that confuses people. Unfortunately, I expect the media will still call it single payer, but you can't do anything about that, so try to correct them. I've been involved in voter initiatives before, and I think they're a very valuable tool. And in fact, I was involved in the marijuana issue since 1979, and trying to end the war on marijuana throughout that time. We made a lot of progress throughout that time. As you said, a number of states passed marijuana decriminalization. Other states passed laws that left you with no arrest record and a probationary sentence. Other states passed medical marijuana. So we made progress, but the voter initiatives were really key. And the first initiative that was key was, there were some early ones that tried and did terrible. They got slaughtered and they didn't help us. But later, when we got into the 1990s, the first voter initiative that's helped us was a San Francisco initiative, where the city passed, I think it was Proposition P. I don't know how they got the letter P, but it worked out very well. Proposition P was the first city initiative passed. And then you went to the statewide initiative, Proposition 215, which was a volunteer effort also. And luckily, they were able to get on the ballot, and then big money came in and helped to fund the campaign, and it succeeded. The general rule of thumb that we started to learn, though, as we did these initiatives, because there were lots of failures along the way too, was that you really need to have volunteer initiatives. In the end, can do a lot of damage, and that you really, and I understand the desire to do it. You got to push things forward how you can. So I understand the the headspace on it, because I share that. You do what you can do. But the general rules of thumb would be you do pre-polling and focus groups, because as you said, when you do polling, you can sharpen your message. You can figure out what issues concern voters and change your language to make it stronger. And you need to be at least 60% support in order to put an issue on the ballot that has a chance of success. Because that 60% support is going to go down once the opposition starts to attack it, especially when you're dealing with an opposition that has lots of money. And there'll be lots of money thrown at, if this gets on the ballot, lots of money thrown at by the insurance industry, the pharmaceutical industry, Wall Street, the for-profit providers. All the profiteers of healthcare will say, we can't let this happen. We're going to do what we can to stop it. So if you're at 60%, you're lucky to win with 50.1%, because that's just the reality of how initiatives work. So I do worry that, I understand why, and this is not unusual, I do worry that you've moved forward as a volunteer effort without having that knowledge base of what the public really thinks, how the language could be changed, because it's a very complicated initiative too. This is not as simple. You can't just say single payer. You can't just say cover everybody. It's more complicated than that, especially with a federal interplay and in the situation. As far as the states being a laboratory for experimentation and becoming the source for national changes, you're totally right. A lot of those changes, those examples you gave, were very early in history, before the United States developed this massive federal system. Right now, probably 2/3 to 3/4 of all the money spent in most states is federal dollars on healthcare. So the federal government dominates it through various means. And so you have a very different system. In none of those cases you described, women voting, ending slavery, even public education, was federal money and federal laws already existing that impacted what a state could do. And so we're in a different, I understand that laboratories, state level, and people having influence on their states, I understand that. But this is a very unusual situation, as we have a very complicated, multi-layered health system where most of the money comes from the federal government, and there are multiple laws. And I'm curious what you think about our concerns about Jamila's legislation, if it impacts Medicare and Veterans Administration and Medicaid and turns those into private systems. I heard what you said about setting a floor of a certain level of coverage.
It really bothers me allowing states to do that.
But setting a floor of coverage that the state can't go below. But what the Paul Ryans of the world will say, we're not going below it. You can get it through private health insurance. And so that's what I really worry about, is how do you feel about us, the single payer movement, providing the Paul Ryans of the world, the privatizers, with a tool to get their dream of privatizing these public systems?
Yeah, and maybe I didn't use the right words, but when I mean set a minimum bar, I think allowing states to publicly fund their own system, not using private health insurance. So like I'm vehemently against the idea of allowing private health insurance more access to our public dollars. It's extremely wasteful. For example, 256 different health insurance plans exist on the federal employees benefits. That's 256 plans that healthcare providers have to figure out, and people have to figure out to know what to do. So like that's not okay. I definitely, so maybe that's the step, is that it's hard to get support, bipartisan support for changes that don't leave that privatization open. But I don't think it's a good idea to allow states to customize their plans in that way.
So go ahead.
Well, I was going to say that, we all share that. We don't want states to be able to go below a bar, but the reality is that if you open that door and put that legislation into Congress, that bar is going to get lowered. If you look at the Affordable Care Act, in the first year or so after the Affordable Care Act was passed, and this was under a Democratic administration, there were about 1,000 waivers that Health and Human Services gave to various entities, allowing them to not comply with the Affordable Care Act. I mean, the problem is that it's very hard to hold a bar. This is why we're fighting for national.
Happening right now. For all intents and purposes, I spend one of my day jobs for the last 4 years is studying the U.S. healthcare system and other systems, and healthcare in general, and trying to help everyday people understand how to find health insurance
We have a
in it, and it's insane. And so that very much inspired me to pursue this effort, is the fact that I know right now HHS and CMS are deregulating the system, and I am not comfortable with. It was shocking to me to discover just how much authority under the ACA they were given and under other laws. I feel the duty to do what I can, and this was the avenue I was given to help shape policy and to make sure that my neighbor across the street who's Medicare eligible and disabled doesn't have copays anymore because he lives in poverty, and it doesn't make sense that he doesn't.
We all share those concerns.
Right.
So the question is, though, how, once the bill is introduced, how do you envision the bill not being amended to allow states to have a privatized voucher system that provides better coverage?
I
how,
don't.
How do you see that
Our
happening?
bill? You're talking about our bill or the waiver?
No, Premillage, I apologize.
Premilla's bill.
To open
Oh, I don't know because I haven't read her language. In other words, I don't know if she's written any
It doesn't matter what
language.
her language is. The language will change once it's introduced. It goes to the finance committee, which is the most corrupt committee you can imagine, and they will change the language and allow states to privatize. That'll be their dream. They've wanted this forever.
This is why the Medicare for All movement has been opposing it for all of these years.
They'll do the same with the VA.
We don't want to open up that box. We don't want to destroy Medicare.
Well, as far as I understand, we haven't been the one pursuing I didn't. Okay, let me back up. So our organization is not the one working with Premilla on getting that waiver. We started out this effort assuming that some waivers would be able to be achieved, some would not, and that we would need to state fund certain things and contract, create a health insurance company. So it will work with the existing system. It will work better if we can get waivers for some of the systems to roll them in directly, but it isn't necessary for our proposal to function. Maryland's all-payer system, which this would mimic in a lot of ways during transition, but Maryland's all-payer system saved $318 million just for Medicare costs in 2016 alone. So and that's what we intend to do. So I'd be recommending that you talk with maybe Healthcare for All and some of the other organizations about some of these concerns, because in other words, I haven't spent enough time studying this particular issue myself to have a position on it. So I like what you're saying. I like that you're addressing these concerns. Our proposal as an initiative doesn't rely on them, though it would be nice if there was some way for our states to get easier access to some of these waivers.
Right. So one of the things I appreciated is that you're being realistic about when you have an opt-in system, how many people will actually participate in it. I think 80%. That's a high number. I think that.
Well, 40% will fall under 200% of the federal poverty level, or are children, or qualify for Medicare. So a big chunk of it will fall under that. And then if you just think of how many businesses will opt in, 80% I find conservative, actually.
Because it actually takes a tremendous amount of resources and work to do the outreach to the different businesses to be able to get them, convince them to opt into your system. And this is something that,
well, it includes a mandate. Our system includes a mandate.
What kind of a mandate?
So under the initiative, essentially what would happen is during transition, businesses can opt out of the payroll assessment, but only if they provide other coverage to that employee. But the way that the payroll assessment is graduated, lower paid employees or those who are just temporary or part-time would cost almost nothing, and higher paid employees would cost significantly less than the insurance coverage the employer is paying now. So it's and they would have to apply for that waiver. So they would actually see the difference in cost in the first year for any employees that they continued to provide the way overpriced coverage to, and their part-time employees who it's a graduated and based on their total pay for the quarter. So part-time employees would cost significantly less.
To participate in your program or get a waiver to not participate?
We are requiring them to either provide ACA coverage to their employees or participate.
That's not something that a state can do, though. That will violate ERISA.
Their employees, ACA compliant coverage to all of their employees, so part-time, any employees. But the ACA coverage is costing them 18 to 20% of payroll right now, and they're only covering about 58% of Washington's employees. So we can lower their cost. Their effective tax rate would be, if they covered all their employees under the plan, the average effective tax rate for businesses would be about 7% of payroll. So we could cut their costs in half.
So how does that not violate ERISA?
Yeah, a state is telling the employers what to do.
Because ERISA is coverage that is all employees have it, and it is ACA compliant.
Yeah, I don't think that's going to pass muster if it gets challenged by.
Court won't agree with that.
But so my mom helped develop and expand the self-employed coverage for Avista in our state, and essentially what we're doing is providing the same kind of coverage, just at the state level. We're self-funding our coverage instead of paying insurers. But ERISA benefits they cover all employees. The idea is to provide better care to their employees. Businesses that provide those kind of benefits will look for opportunities to be able to save money and continue to do that better.
Well,
and this plan,
good for them. It's a question of whether it legally allowed to do that.
They would be allowed to opt out because they cover all their employees. That's part of ERISA. Okay. They cover, that's self-employed companies cover their employees.
Right. That's how the majority of employer insurance is.
No, the majority of insurance coverage only has to cover their full-time employees, and it's only businesses with over 50 employees. Like, in other words, ERISA benefits are applied within the company differently than other health insurances. And I'm confident that a bunch of those employers, the reason they pay so much for ERISA benefits so that they can self-fund coverage is to provide better care for their employees. I'm very confident that giving them this kind of option is going to get the majority of them. Maybe it doesn't get all of them, but again, the larger the risk pool, the larger the bargaining pool, the better. So maybe we don't achieve the maximum savings, but over time, this program will get cheaper and cheaper and the benefits will expand.
Yeah, I think, there's been a long history of states trying to create these kind of patchwork systems to try to get efficiencies and cover the uninsured. And each time that's happened, the states have found that in reality, they're able to cover many fewer, much lower percentage of people than they had aspired.
As far as I know, there is no state-based plan that's ever passed that's been universal and state funded, had funding.
We're not having a conversation.
Right. We couldn't hear you because Margaret was talking, so you interrupted. I couldn't hear you.
As far as I know, there's not been a state
I actually want Margaret to finish, but
no, don't worry about it. Don't worry about it.
No, I'm sorry. Go ahead. I can't
remember what you were saying now.
No, I remember what I was saying, but I think that I would like to be able to finish my point before you make your point.
Yes, please. I'm sorry.
So states have found that when they've made these efforts that they ended up covering a much smaller percentage than they had anticipated, and they found that over time the costs ran so high they didn't achieve savings, and actually the plans failed due to cost. I think what we have learned is that when you have a system that allows private insurance to operate inside that system, that it's really pretty impossible to achieve savings and get the coverage levels that you want, because insurers are very skilled and have a tremendous amount of resources. So even though we think that, well, our plan is so much better, people should just choose it because it's so much better. But the reality is that the insurers have much more resources to convince people that their plan is much better, even though it isn't. And so this is the reason that we fight for a completely public system that keeps the private insurers out, is because we've found in the United States that we can't regulate them, and we can't they run end games around us. We don't ever run end games around them. So I hear in you what I felt 14 years ago when I wrote our state bill. And when we brought people together from around the state to write what we thought was a really excellent bill. And I understand your passion and you know, we live in Baltimore, Maryland. We have tremendous levels of poverty in our city alone and throughout our state. And so we see directly the impacts of the system on people. So I just, you know, I think if this is where your passion is, this is where you have to go. I'm glad that you're being realistic about, you know, that it's not a single payer. And, you know, I'm not going to argue with you or try to talk you out of doing it.
No, I'm not aware of any state that has passed a universal system that everyone could enroll in that was had actual state funding attached to it. I'm not aware of any state that's done that.
I think we have your email. We'll send you some things.
Okay.
And you know, also your point is right that the bigger the pool, the more savings and less bureaucracy, and you can get cheaper rates. I think that's as a general principle. But then when that principle is also applied to the insurance industry still being there and using their money to play their marketing games and end arounds the law and the stuff they do, once the insurance system is still there, the infection is still there. You know, 1/3 the cost of our healthcare system is because we have an insurance-based system. About 17 or 18% is the insurance companies. The other part of the third is the bureaucracy that they create, and so that's still going to largely exist. And so you're not going to get the savings you think. I'd love to see what Gerald Friedman would say if we put forward the question to him.
So
that included.
I would love that. Yeah, I'd love to send a list of questions actually. But my first comment or my response to that is that the cost, the premiums going down over time is part of what makes it a better plan. I get that private insurance aren't excluded, but our proposal actually pushes them into a supplemental market. It allows insurers to add additional benefits and things like that. Other countries that have pushed private insurance out through this kind of style by going with a publicly funded plan that means the premiums can be so low that private insurers won't compete. They would have to set their premiums so low that they would not make a profit on those benefits. So instead, they'll leave the essential benefits market like they have done in Norway and Germany and in Switzerland and start focusing their benefits packages on what's much less risky, which is supplemental insurance, things like private rooms in the hospital, providing travel reimbursements, long-term phone calls from your hospital room, extra benefits for amending your home, changing how your home so that it's functional if you get injured. They cover things like, it's called Cush Care in Norway, but those things don't exist in the United States because the private insurance market has never been pushed out of essential healthcare. This does it by making it not profitable to exist in essential healthcare anymore. They would have to drop their premiums to an extent that they would not make a profit anymore. But I'd love to see how they'd try. I mean, I just don't think they would even try.
I got involved in this 20 years ago over the writing of the Washington Health Security Trust bill, which we tried to run as an initiative in 2000. But I curbstoned a then active federal appellate judge on the subject of ERISA. And I said, if we did as we were planning, we would fund it with a payroll tax that would apply to all employers. It would have a cutoff for low income for small businesses, but everybody would pay something. And the companies, the self-funded companies, could do whatever they wanted, but they would be paying the payroll tax. And so I didn't think they would pay double for very long. In other words, why pay for, why pay for insurance for your employees and pay a payroll tax if you don't have to do that? And I asked my friend whether she thought that would be ERISA compliant, and she said she did think so. Now that's just curbstoning one federal judge who is since deceased. 20 years is a long time, you know, for federal judges. But anyway, I think that's the general approach that Whole Washington is using also, that everybody pays the tax. If you want to keep on paying for your employees' health insurance on top of that, feel free. And I also wanted to point out that by no means all employers fall under ERISA. There are plenty of employers who are not self-funded, who are simply trying to buy insurance as a small business for their employees, and they're having a terrible time.
Yeah, no, we agree with you on that. So general thinking, I think now, 18 years later, on payroll taxes is that they would actually be viewed by business employers as coercing them to choose a different plan for their employees, and that would be restricting the choice of plans that they could offer their employees. And so I'm not sure that a payroll tax would be able to stand up in court. I'm going to have to find the specific case for you, but that's the concern now, that the legal precedents that have been set, that would be a problem.
Over the last 20 years, it was.
Yeah.
Well, remember, it was one federal judge that I curbstoned. It was not a case. So who knows whether there's been anything whether there have been any such challenges in existence. I have not researched them, but the idea was to try to have something that is for the public good. It's a general tax. States do have the right to levy taxes against employers for the public good. Oh, and the other point I made is no exemptions. So the Boeing company is not exempt.
Actually, I remember the case now because it was actually the Maryland case. It was a bill that was a pay-to-play type of thing targeting Walmart. And it was basically that either Walmart had to provide a basic coverage for its employees, or it had to pay the state money that the state could then use to subsidize coverage for the employees. And the case was decided in favor of Walmart because that payroll tax was restricting their ability, their choice. That was in, I think, 2007, maybe, or 10, somewhere around there.
Okay. But there's a key difference here. Walmart was being offered a pay-to-play choice. In other words, you either insure your employees or you're going to pay this tax. What we would be saying is you're paying the tax anyway. You can do whatever you want with your employees. The tax is our state's right to tax employers for the public good. No exemptions.
Yeah, when I look at the
proposal does not eliminate supplemental insurance.
Right, it's such a broad. There's so much leeway in the RISA laws that really it depends on the judge, because they could make anything sound like a violation of RISA.
We still have to realize that, like, the reality is the majority of employers are not providing ERISA benefits in any way. The significant majority of employers are paying significantly high costs, twice what we're asking them to pay, for better coverage that wouldn't require their employees to pay a bunch of out-of-pocket costs on top of that, have deductibles. So it's the large majority of employers will see this as a better option. Small businesses are paying between 24 and 55% of payroll if they decide to provide coverage. And a lot of small businesses are supporting what we're doing because they want an opportunity to provide coverage for their employees. Right. So the large majority of businesses across the state will opt in because it will cut their costs in half and provide better coverage for their employees. If a few don't, they're already provided coverage under ERISA benefits. It's not going to last for long. At some point, their employees are going to be demanding that they get the state plan. It would save hospitals are employers too. It would cut their costs in half. Federal employees that's a cost too. Oh, it would cut those costs in half. Like, you have to keep understanding that you cut the cost in half for businesses of all kinds. And you tell me that what businesses are going to say no.
I guess we're just having a very hard time believing that you're going to actually be able to cut the cost in half.
I can guarantee you in the campaign, the insurance industry will be sure to say your numbers are fake. I mean, I'm sure that in a campaign, you're going to have a very hard time when the insurance industry puts their money into disproving your possibilities.
Okay, well, it's not impossible. It's not impossible. It's not impossible because we layer the funding. It's funded through individual taxes as well as taxes on businesses. It's not impossible because most people will elect to enroll through their public program because it will offer better benefits. Medicaid is going to be the hardest one, and that's going to have to be led by providers. Providers saying, hey, if you enroll in the state plan, I'll accept you as a patient. I don't take Apple's reimbursement rates, right? That one's going to be tough because their benefits don't really expand except to add vision. But the other benefits programs, this will offer better coverage at a lower price than anything that they have available to them now. People want a better option. People want to stop spending on GoFundMe's for their insulin. We can give them that option, and people are clamoring for it. We have long-time paid signature gatherers who say that this is the fastest they've ever been able to gather signatures, that they've never had this kind of ease with talking to people about something like this. The time is right now. And I'm just excited to be a part of it, but there is no reason to assume that we can't make huge, significant changes at the state level just because there are challenges and ways we have to navigate the federal system. We've looked into that, and we've written in proposals that it's flexible and the board will be able to do its job.
Hi, my name's Pam Nolan. I'm an RN, and I have been working on single payer since last year. I was new to the effort, and I certainly do believe in HR 676 as being much better than any state plan or Bernie's plan. I'm with you on that. My comment, and then I have a real question. My comment is that I too am a signature gatherer, and it is stunning how people grab me like a lifeline and say, yes, I have to have this. I am so worried. I'm so frightened. So it is becoming a strong citizen mandate because it's so miserable for them. And they can see what's happened to the ACA and how little regard the GOP government at this time seems to have for whether or not they die or live. And I know that sounds very dramatic, but that's how it feels to people. I would also like to say that, what was I going to say? She was talking about unemployment insurance, wasn't it? What did you say?
No, people who are uninsured, that if you pass these, if the initiative passes or if we pass any other state plan like this, it ends uninsurance.
This will end uninsurance if we pass something like this. So I just wanted to let you know that I really think that our senators who are very, very careful to say they support a universal plan, but it should have a public option and we shouldn't mess around with the private insurance companies because they don't want to lose support for their seats in 2018. If we can collect a huge amount of signatures for this and it goes to the ballot and people vote for it in even a fairly large minority, this is going to help move our legislatures toward the fact that citizens are demanding this, they're begging for it, and they are not listening. And I think if it happens to gain a lot of support in Washington, even if we don't pass it, I think it gained a lot of support in California. I think it's building momentum towards single payer. Most people would prefer single payer that I have met. My question is, I've been hearing from a lot of people as I gather signatures, well, don't you know what they're doing in Massachusetts? And the answer is, no, I don't know what they're doing in Massachusetts, but I'm told that it's a much better plan than most states have, and I'd like to know what they're doing in Massachusetts.
So I just want to say that, I agree with you that the support right now for a single payer healthcare system, the level of desperation is very high and the support is very high. We're seeing that, everywhere that we go as well, talking to people about national improved Medicare for all. And, in all the years that I've been doing this advocacy, I've never seen such a high level of energy for, Medicare for all. This is a part of the reason why we feel like focusing at the federal level is so important, because it feels like we're, after literally decades, you could even say that there's 100 years of history in the United States of fighting for a national health insurance. We're finally feeling we're at this phase where there's a lot of support for it. We're starting to get political movement on it. Now I'm trying to remember the question.
Massachusetts.
Oh, that's right.
So it's not surprising that people you go ask signatures for, do you support cutting the price of insurance and making it available to everybody so everyone gets rid of insurance and businesses save money? Of course, you promise them everything. They're going to say, yeah, that's fantastic.
Right.
I'm not surprised because there's desperation on every level.
Right.
People see their neighbors and families struggling. They see businesses struggling. They know it's not working. They know we have a crisis.
Right.
So promise them an alternative. Of course, they'll sign on. Doesn't mean it's going to, in the end, be what you're promising.
Yeah. Now, Massachusetts was the first state to pass a plan that's similar to the Affordable Care Act. It was the model state where they tested out the Affordable Care Act. It was passed under Mitt Romney, a Republican governor at the time. And, it's basically, they have, mass care. They rolled their Medicaid, I believe, into that. I know they added co-pays for Medicaid. So, I'm not sure who's telling you that it's such a great plan. It has a lot of problems.
But it's basically a private insurance plan. It's not a public plan.
It's basically the same thing as
it's the ACA on a state level.
Right. So they created a health insurance exchange at the state level. They
subsidized insurance.
Right. They subsidized insurance. And I'm thinking in terms of the outcomes, they were able to reduce their level of uninsured people by about half, which is that's about the best that anyone's been able to do with these types of approaches at the state level. They did add co-pays in for Medicaid, so that was a problem in that Medicaid patients were then foregoing care because they didn't have the money to pay the copay up front. Another problem that they've had is that they anticipated a large reduction in the use of hospitals for uncompensated care or the uncompensated care at the hospital level, because they said, oh, well, so many more people are going to have insurance, so obviously our uncompensated care is going to go down. And what they found is that actually that didn't go down, and a number of the hospitals had to sue the state in order to get that safety net money back from the state. So it's very similar to the ACA. It was passed in 2006, so it's been around longer.
That's one reason why it was surprising to a lot of people that Republicans opposed the ACA, because the ACA came out of a right-wing think tank, the Heritage Foundation. Mm-hmm. It was endorsed by Newt Gingrich when it was first came out, and Mitt Romney was the pilot for it in Massachusetts, and then Obama took it national. And so he took a conservative Republican pro-insurance plan that was tested in Massachusetts and applied it nationally, but then the national Republicans opposed it,
Right.
mainly because it was just a partisan fight.
Yeah.
They just saw political power plays. That's what that was really about. And so when people say, if you look at the details of Massachusetts, you'll see it's just the ACA and it's about as effective as the ACA as well.
Right.
Okay, let's go to the next question. We have a bill from
So in Washington State, there have been a couple of critiques that I've heard. Well, no, now in general, now there's been two critiques of Whole Washington's initiative. And one has been that, wow, we're just not ready. Like, why are you like going faster than the rest of us and don't do it? Because hold on, we can do it all together and we can make it happen. But in reality, that's coming from people who've had years to fucking do something and they haven't done anything. So, and then there's this interest, but they're still talking about, well, what we could do in Washington State. And then there's the your very interesting critique that we should wait and just work on the national piece, and this could be detrimental to that. I'm really gonna have to sit with that for a while. I've been a piss poor supporter of Whole Washington, but I felt impatient with folks critiquing them too much when I felt like so much energy could be spent critiquing that could actually be spent supporting and organizing. Now, you all throw a new sort of concern into that again, I think we all deserves to be pondered. I am concerned, Erin, that the numbers and the tone a little bit comes off as maybe a little overconfident and too optimistic. I'm a little concerned about feeling like true believers rather than having an absolutely bulletproof plan. And I'm not saying that you don't or that Whole Washington doesn't. I'm just saying that I'm a little concerned now because that in the tone. Okay, and then so there's that piece, and I wasn't aware that there that there was a payroll tax, and my bad, because I have always wondered how we were going to fund this. And in Washington State, I think Margaret and Kevin probably know, but if not, I mean they should know that we don't currently the payroll tax sounds a lot like an income tax, and maybe it's not, but it does sound like it, and we don't have that here. I think we need it.
We do actually. We do. They just passed the paid maternity leave, and it included a payroll tax. It's just not implemented yet.
Great. Okay. But what we really need, we also need an income tax. So I'm just pondering these different critiques, and I'm wondering also from the conversation around how the response is from the signers. I do admire that Whole Washington is out there actually collecting signatures and talking to people about this. And I think it's because I'm pretty damn impatient for the national thing. I'm not confident. I mean, we saw like when the Republicans put it up for a vote, right? Nobody voted for it. And I know that was just some sort of a hoax thing they were doing. But anyway, some months ago that happened. So it's hard to feel confident that that's going to happen. And I wonder if it's possible that we can achieve some value of what it feels like what we really need, and what I feel like I'm repeating myself in this context. I just want to finish this one thought, please. That what we need a movement building strategy that's reaching people and having these conversations, and the Whole Washington is at least doing that. And I don't see anybody else in Washington State right now doing that. And so maybe there's a way to leverage this to begin those conversations. That's all. Thank you. Check.
Yeah, George Martin here. You know, a few years ago, our board had a discussion. Well, first of all, we were very impressed that the state of California economy is the 6th largest economy in the world, and that they're neighbors along with Oregon. And we thought, well, I'd like to get feedback on a critique of it. Maybe the way to go would be a Western consortium of contiguous states or nearly contiguous states, because at California would have to be it because it's a huge population. And there's interest in that right now in the state of Oregon. We've heard from them, and they're planning a meeting on May 20th they call it a tri-state, but Hawaii might be involved, at least Skyped in. Steve Kemble is quite interested in that. So I'd like some feedback. You could maybe ameliorate some of Margaret's 9 and Kevin's 9 points of problems a little bit, but they still have those problems, and a tremendous administrative problem trying to get equitable funding. The state of Washington doesn't have an income tax to start.
Let's let them answer.
Yeah, and then, so give us your feedback about it, if that's something we should think about.
So, and this maybe will help to address Bill's point too, his impatience with the national approach. And actually, Bill, when that senator put out the HR 676 amendment, Sanders told the Democratic senators not to vote for it, so that they would all be like in lockstep against it. And he called it a hoax and all this, and so that was, I think, a big part of the reason why they didn't vote for it. And I'd like to hear what Bill thinks about this as well. But, so we know that if we're trying to build a social movement and we're trying to win something, that it takes a long time to do the organizing and building of the momentum to make that happen. And that if anything that you're doing towards that goal needs to be actually moving you towards that goal. And so to have, 3 of the big progressive states in our nation peel off of that fight for national at a time when we have the record number of co-sponsors, Democrats, that have signed on to HR 676 by far, 122. We took Senator Sanders from a position where he was refusing to introduce a Medicare for All bill last year and pushed him to introduce a Medicare for All bill. And not only that, but 16 other senators signed in on as well, and a number of them ones who are running for, considering running for president. That this is becoming widely debated in the public sphere about whether single payer, national single payer, is becoming a litmus test in the upcoming 2018 and 2020 elections, where institutions like the Center for American Progress, the Democratic Party think tank, is coming out with proposals that sound like Medicare for All. They call it Medicare Extra for All. And members of Congress in the House and the Senate are introducing legislation, various Medicare buy-ins and public options and what have you, all using terms Medicare, because they are, as we know, in stage 6 of social movement, movement action planning, they're trying to appear like they're doing something. So we have a time now where we're actually building that momentum to pass a national improved Medicare for all. And in my personal opinion, anything that we engage in that is not focused on that fight is taking resources away from that fight. And I feel personally, as someone who lives in it's a border southern state, but it is a southern state, and we have quite a lot of racism here. We have quite a lot of health disparities and poverty and suffering. And the last thing that I want to do is leave my people in the lurch and not be engaged in a fight that makes sure that every single one of us has access to the healthcare that we need, not just the richest state in the United States. Because let's be serious. If a state actually does the work of creating a campaign to try to pass it at the state level, we're talking a very long period of time to make that happen. California has been introducing single payer legislation for a long time. In 2006 and 2008, they got it passed because they had a Republican governor, and the Democrats did it because it was popular with their constituents, and they knew that it would actually not become law. As soon as the 2010, when Jerry Brown is running and the Democrats know that he's opposed to it, none of them would even step up and co-sponsor the legislation. And I had dinner with the Senate co-sponsor, lead sponsor in the Senate, in 2010 with his chief of staff. And she's told me, Democrats don't support single payer in the state of California. The only reason they sign on to it is because it's popular with their constituents. It's an easy one because, you know, they're not going to actually, it's not actually going to get passed. And so here we are now, you know, 8 years later, and California's done this tremendous effort again, and the state has made what we think is a valid assessment. They've actually realized that you can't get these waivers or these changes to federal law, and that there are all these barriers, and they're going to focus on trying to do things at the state level.
And as a result, it's going to be very expensive.
That they can do. So,
and as a result, it's too expensive to do a multi-payer system.
Right, but if a state actually did achieve passing a state bill, then you're talking about all of your efforts are going to be engaged in applying for waivers, trying to get changes to federal law, trying to fight off any ERISA challenges that are made. And so your energy is going to be consumed inward on trying to do your state system. So in our viewpoint, or in my viewpoint, that's taking you out of the fight when we need you right now for a national improved Medicare for all.
I don't think anyone here is backing away from a national Medicare for all effort. So it's just a little strange. Like, I certainly have been more inspired to tell people about the national Medicare for all movement. And then I can use state-based examples as to why bargaining power works to reduce prices and how improving the system helps. If nothing else, from a ground perspective, this is engaging people to understand the challenges that we face as a movement for national healthcare in a way that they've never been engaged before. So that, like, for me, I would love it if we make ballot. I would love it if we won on the ballot. But I'm already exceptionally excited just to have people asking me questions and talking to me about policy. I've been spending years trying to get everyday people to talk to me about policy, and because they can look at it through a frame that's relevant, they're willing to talk to me about policy. So that the idea that it hinders the national effort to build awareness and educate voters about what these things do and how they work is, I just think it's a little disingenuous. I definitely don't want to hinder the national movement. I'm here to help further national movement.
If I could respond to that, and I'll be honest, I don't appreciate being called disingenuous as somebody who's been fighting this with everything I have for a very long time. But there's you don't need a state campaign to talk to people about single payer. We don't have a state campaign in Maryland, but we have a growing healthcare as a human right campaign here. And the reason that our state our Maryland members of Congress, that we doubled the number of members of Congress that have signed on to HR 676 is because our state activists engaged in a targeted campaign towards those members of Congress to get them to sign on, and succeeded. And now we're turning to our other, well, really 3 of the 4, because 1 is pretty impossible, but now lots of people are challenging him in the primary. Turning our attention to the other 3 to figure out how we can move them. So if you're focused on collecting signatures for a state bill or lobbying state legislators for a state bill, you're not actually creating a strategic campaign or mobilizing people to impact your members of Congress. So that's why we say that the state efforts don't necessarily help people, because there's lots of ways to engage people around HR 676.
We are, though, because we are telling our supporters and volunteers to engage in the efforts that we are actually providing assist to other organizations. We're like, hey, this state organization is doing this. This federal level organization is doing this. Hey, another person co-signed this legislation. So, like, in other words, we agree with you. That's why we've always taken the approach of educating people on all aspects, and that we are an organization that supports the movement as a whole. So I agree with
meetings where you're outlining strategies to impact your members of Congress, or are you telling
meetings to educate people about the current healthcare system and how it works and what's wrong with it and where the dysfunctions and challenges lie, for sure, in ways that they've never asked questions about before, in ways I've never been able to get them to communicate with me about it before. They're getting to understand what's happening at the state and federal level in a way that they've never been interested in getting into those details. Now, it's not everybody, but it's more than, I'm pleased, I'm excited. It's the thing that keeps me going, is I've never seen people be this interested. And if there's ways that we can continue to help with that effort, or ways that we can help that effort more, just send us an email. Our board would love to look at that. We want to help the national effort.
I came to this meeting because I wanted to get some clarity about the problem of waivers, and we've hardly discussed it. And my question is, are we going to have uniformity here in terms of all of us about not supporting any kind of attempt to get a waiver at the congressional level? Because if in fact our representative Jayapal is going for legislation to allow a waiver, to allow waivers to facilitate state universal care programs, and knowing that that can lead to the destruction of Medicare, I can't support it, and I don't think any of us should support it. And I think we should come to some kind of conclusion here tonight about whether we're going to support something like that. So that's my question, because I think it's out there, and you know, once that bill gets dropped, we better be having some idea of what we're going to go for. And I've been looking for the bill too. Maybe she's not going to do it. Maybe she's going to do what McDermott did, which would be just fine. But I'll also just comment that as a person who is on regular Medicare, not Part C, I'm very distressed that increasingly there are all these new parts to Medicare being proposed, which only makes Medicare even more difficult and further away from an improved Medicare. And I think we could well put our efforts into improving or restoring the Medicare that we do have as a project and as a way to build towards national improved Medicare for all, rather than trying to do a lot of other new types of projects. Oh, sorry. I'm looking the wrong direction. Sorry, I'm looking up. Anyway, but I would really like, you know, obviously you've already talked about the waiver, both of you, Margaret and Kevin, but I would like to have Erin's promise that that Whole Washington and the people working at the state level are not going to support a federal waiver bill.
Well, like I said, we won't support things we haven't seen the legislation on. That's first off. I just know that our organization wouldn't endorse or not endorse those kinds of things. We just don't have a tendency to endorse things in general. But what I will say is I can't speak for the board, but these are the concerns that were brought up here. I totally understand them, and I have similar concerns personally. But what I can say is that I will talk to the board about it, and see. In other words, like once there's legislation to look at and we can see what she's proposing, or if we have an opportunity to look at it a little closer, perhaps they would write a letter of a position on it, but I'm not even sure that would happen, public position. We tend to just focus on educating people when it comes to those kinds of things that are a little bit outside of the state. So we don't, as an organization, I don't know that we've endorsed anything.
Could I respond to the waiver question just really quickly? So there are actually only like 2 waivers that we're talking about. One would be a waiver to get a state out of the Affordable Care Act, and the other would be a waiver to get the Medicaid, allow the Medicaid system to be put into the state system. The other things that we're talking about are all changes to law.
Right.
They're all change, congressional laws that would need to be changed. And so why
doesn't the Maryland waiver on Medicare apply?
Well, the Maryland waiver on Medicare was just allowing the state of Maryland to set the hospital rates. And it doesn't actually give us control over the Medicare dollars like you're talking about if you integrated Medicare into your state system. It just was giving the state the power to regulate the hospital rates, which applies to all insurances, including Medicare. And I believe that in addition to that, we negotiated with Medicare that we would get higher Medicare reimbursement rates than the average in the country as part of that controlling our hospital costs. My partner, who's the other co-chair of the Maryland chapter, that's his area of expertise, so I tend to let him be the one to talk about that. But I could definitely get more information if people are interested in that.
One other thing I'd recommend that one of your groups that is involved in this look into is Medicaid. Who is running Medicaid in your state? No doubt it's some kind of private insurance entity.
Yeah.
Maybe under a different name, but that's what it really is.
United Health.
They usually have a very high overhead rate.
Yep.
Probably 40 to 50% of the cost of
In some
Medicaid. In the few states where we've actually gotten to see that, it's that 40 to 50% they charge for administering Medicaid. We have this in Maryland, where our Medicaid program is run by a private insurance corporation. And we have another, and we've seen some documents that kind of indicate it's over 40% of the cost of Medicaid, their overhead. But there's another program in Maryland for children with chronic illness who are on Medicaid, and that's managed by the state. And that only has under a 5% overhead, 2.8% overhead. And so you may want to look into whether or not your Medicaid dollars are going in the pockets of insurers rather than to healthcare. I think that's worth checking into, and that may be a worthwhile campaign to deprivatize Medicaid and make it a public system again.
That's something that Connecticut and Oklahoma did. Oklahoma's ended up getting reversed by a governor that came in, but they found that they're saving a lot of money and they're able to provide more benefits, and they have more case managers. So they're getting, higher quality of care because they have a completely public Medicaid
And
system.
Connecticut successly did that.
It's continuing to, yeah.
In Connecticut, yeah.
Okay, well, we need to end it, and thanks for the comments on Medicaid. I was thinking about that. Anyway, thank you very much. There's going to be, this is going to be on video. It's going to be put up on YouTube, and I'm sure David will let you know exactly how to do that. So let's have a round of applause for Margaret and Kevin and Erin.
Thank you all for your work.
Yeah, thank you.
This was really good, and I hope Margaret and Kevin get some sleep.
Thank you.
Thank you all very much for your work. We really appreciate everything you're doing.
Yes, we do. All of you.
Okay.
Bye-bye.